causing leading to interesting renal manifestations, whether that's an acid-base manifestation, whether that's things like membranous minimal change disease, weird paraneoplastic GNs. My personal interest mainly is paraproteinemias, so monoclonal disorders in the kidneys and amyloidosis is primarily what I focus on. But yeah, a whole array of TMAs also that we get to manage and see. So a lot of close working with our cancer providers, our heme doctors and onc doctors to make sure we provide comprehensive cancer and renal care. This was not necessarily a specialty, maybe 10 years ago, 15 years ago. So it's developing, blooming, and hopefully this is one media where we can get some of the information out. So thank you for having me again.
Sure, thank you. And Epi, do you want to share a little bit about what do you like in the medicine and what do you like outside of medicine?
Yeah, I like medicine, especially nephrology, because it gives me the appreciation to see the whole gamut of medicine, including all kind of specialties as well. Because like we get consults from all kinds of specialties, OB/GYN, orthopedics, and internal medicine, and also the surgery. And I, gain the experience of seeing the advanced therapies and management in other specialties as well. So that's why I like nephrology. And outside medicine, I like to play games, especially Nintendo Switch. I like Mario Kart and Super Smash Brothers as well.
That's so cool. Thanks for sharing that. And friends, I also wanted to remind you that it's a wonderful coincidence that Dr. Chowdhury actually has presented a case on VMR before when he was a fellow, I believe. And Epi has actually created the schema of glomerulonephritis, which is on our CPS website, and you should check it out. It's really good schema. So it has, I guess, never happened before that we have discussion and we have presenter, both of which have participated in VMR before in different ways, and now we have them again. So I think it's going to be great. And I also wanted to thank my friend Jia for scribing today and Kushal for helping with the teaching points. So I guess we can start with the first aliquot. Epi, let's start.
Sure. So I have a very interesting case. He is a 70-year-old male who presented with worsening bilateral lower extremities over the past month.
Okay. I think this is a good start because this is one of those complaints which everybody sees. Like if you are EM physician, you can see this, and even if you are like IM resident, you will see this. So Dr. Chowdhury, can you tell us more about how do you approach such a common complaint?
Yeah, so essentially the chief complaint is edema, lower extremity edema, and for me, it's always about my fundamentals when it comes to edema. Is it cardiac? Is it hepatic? Is it renal? And then the miscellaneous bucket. Miscellaneous is always things like endocrinopathies, medication-induced, obviously venothromboembolic phenomena. So those are three things that I really try to hone in on when I'm reviewing the patient, examining the patient, going over their meds, and doing the review of system accordingly. But that's my main approach to edema.
Yeah, that's great. I think putting it in the buckets really helps us. So yeah, Epi, can you tell us more?
Yeah, sure. So this patient, he was in his usual state of health until around a month ago when he started to notice that his legs became more swollen gradually over the past month. And he also noticed that he gained 10 kilos within the past month. But he denies any fever, no chills, no shortness of breath, no chest pain, no abdominal pain, didn't notice that he has any increase in terms of his abdominal girth, no nausea, no vomiting, no dysuria, no hematuria, but he did notice that there are more bubbles in his urine, and it's very hard for him to flush all the bubbles away in his toilet. And on top of that, he also endured some kind of mild tenderness in his calves as well.
Perfect. Thank you. Thank you, Epi, for sharing that information. And actually, this is a perfect point in the discussion to ask Dr. Chowdhury that how does he interpret this history which people give of bubbly urine? Because oftentimes we see this in the clinic and people will say, oh, my urine is foamy. But then it's really hard to make sense of that. What is the degree of foaminess which is expected as normal or not? And if you indeed have foamy urine, how sensitive or specific it is for any particular disease in general, especially kidney disease. So can you share your thoughts regarding that, Dr. Chaudhary?
Yeah, I get this chief complaint a lot, a bubbly urine. I've gotten consults for normal renal parameters and foamy urine. To me, I don't put a lot of stock in it unless you're telling me stool is sort of floating and on, in your urine, and you have sort of obvious lipid droplets. It really doesn't help me much in any way from a sensitivity specificity standpoint. I still go back to my basics when it comes to edema. Is it heart related? Is it liver related? The foamy doesn't help me push that towards a renal diagnosis, to be very honest about that.
Sure, sure. And my second question would be this, that often, as you said, that once we have edema and shortness of breath, in general, we think about heart problems, liver problem, and kidney problems. And any particular point in the history or like past medical history examination that you think which can help us in choosing between those three organs?
Yeah, so that's a great question. So now we don't have a whole lot of the past medical history yet. So by the selection bias of patients that I see, and when I look at those buckets, things that I wonder about, obviously cardiovascular risk is higher in patients that are receiving systemic therapy. One thing that I think about is there a medication that's causing some degree of cardiomyopathy to address the cardiac bucket? Things that I think about, trastuzumab, Herceptin is the other name. Then if it's not the cardiac standpoint, there are also chemotherapies that actually cause endothelial dysfunction and can lead to edema. And that may not necessarily be cardiac, hepatic, or renal. It may be more of endothelial miscellaneous vascular complication. So one that I think about, gemcitabine, commonly causes quite a bit of edema. So to keep in mind, it's the patient population you're targeting. Obviously, if this is a diabetic patient, it's likely cardiac versus renal till proven otherwise. But it's just also the population that'll help you hone in on the buckets a little bit more.
Sure, that's amazing. I love it that how apart from the three organs, you also reminded us that some medications can cause it, and I will try to remember this gemcitabine. That's a cool part. So yeah, Epi, we are ready for more information.
Yeah, so in terms of his past medical history, he has a history of hypertension and also AML as well, which is IDH1 mutated AML. He initially treated around a year ago with the induction therapy of cytarabine and idarubicin, and then followed by the ivosidenib, and then followed by the stem cell transplant a year ago, which is the match unrelated donor, allogeneic reduced intensity conditioning regimen, and his conditioning regimen was fludarabine and melphalan about a year ago. And in terms of his family history, nothing significant, no significant surgery in the past, also no history of alcohol use or illicit drug use. He was a former smoker, but quit it around 20 years ago. And for his medications, he's on hydrochlorothiazide, 25 milligram for his hypertension, and also prednisone 5 milligram and tacrolimus 0.5 milligram twice a day, Bactrim once a day, omeprazole 20 milligram, and the ivosidenib, which is the IDH1 targeted therapy for his AML.
That's great. So, Dr. Jadri, as you were alluding to, that maybe the medications and the past history can guide you. So now I had like two questions. The first question I had was that given the fact that this patient had AML and now we are 1 year past the treatment, so how does that help you in framing the differential diagnosis?
Yeah, it helps me quite a bit. So I'll put AML in the myeloid bucket disorder. And then the question is, how do myeloid disorders impact the kidneys? People that have myeloid disorders, they can have multiple renal manifestations. And I encourage everybody, regardless of the complexity of the past medical history, it comes back to one simple schema, which is pre-renal, intrinsic, and post. In cancer patients, they're prone to pre-renal insults due to either from chemotherapy that leads to cardiac injury, and they're in a low EABV state, or from poor PO, nausea, vomiting, you can be in that pre-renal state. But myeloid disorders, they do some very interesting intrinsic, they're associated with some intrinsic renal changes. They are associated with some interesting glomerular nephropathies. We have literature suggesting that myeloid disorders can sort of cause infiltration of the kidneys, and you could see extramedullary hematopoiesis. Myeloid disorders are associated with certain GNs like IgA nephropathy. So definitely something to think about. Then you think about the therapy that they've received, and the one that's really important to wrap your head around is a stem cell transplant. So if you take that AKI framework, pre, intrinsic, and post, it becomes a little bit more nuanced in a stem cell transplant. And I guess we can talk about that a little bit more as we go along this journey. In terms of prioritizing the medications, the one that definitely stands out is the tacrolimus. Tacrolimus can definitely cause some degree of prerenal AKI through vasoconstriction of the afferent arterioles. It can cause ATN and supratherapeutic levels. It can also cause thrombotic microangiopathy, which is a bucket term for all types of endothelial dysfunction. TMA in the kidneys would give you proteinuria, usually not nephrotic range, but can definitely give you proteinuria. And when you're thinking about a TMA lesion in the kidneys, it's a little bit of a different beast from systemic TMA, and we can talk about that later when we bring the stem cell component in. And the main thing with tacrolimus-induced TMA, the one thing you'll really notice is the blood pressure starting to take off along with the proteinuria.
That was great, Dr. Chowdhury. I love that how you tied in the malignancy as well as the side effects which can emanate from the medications which we are using. And I guess my second question was this, that since the AML happened like 1 year ago, and we are hoping that it was successfully treated, and this HSCT, like the stem cell transplant, also happened like 1 year ago. So I wanted to learn from you that what's the time frame after stem cell transplant in which you expect different kind of complications?
Yeah, excellent question. This could be a grand round in itself. So generally speaking, AKI, peri-stem cell AKI happens in about a third of the patients, 30% of all transplant recipients. At the Dana-Farber, we probably do most transplants in the United States. So in our literature, roughly a third will have an AKI, and there's various reasons for that, risk factors such as GFR going into transplant, things of that nature. The more catastrophic AKI events, you'll see early transplant, so within 10, 15 days. So if I go back to my AKI bucket, post-transplant, person gets a bone marrow transplant. If I go back to my pre-intrinsic post, pre-renal, very close to post-transplant, I think about these exotic disorders such as sinusoidal obstruction syndrome, which is essentially toxicity to the liver sinusoids. It behaves very much like HRS, actually. The other thing that I think about, very acute post-transplant within the first couple of weeks, would be acute engraftment syndrome or cytokine release, very similar phenomenons where you have widespread cytokine manifestations leading to a low EABV state, leading to a prerenal AKI. Early post-stem cell intrinsic injury, the catastrophic one usually is some sort of thrombotic microangiopathy, whether it's stem cell related, whether it's tacrolimus related. Sometimes what often happens is people may have an underlying reason to have, let's say, atypical HUS or TTP sort of quiescent in the background. Then you add a layer of immunological activation, and it sort of manifests as a second hit of TMA. So each of these TMAs are treated very differently, very acutely post-stem cell transplant. After the 100-day mark, post-stem cell transplant, you get some of the more chronic manifestations of kidney injury. They usually are in the form of nephrotic disorders that usually happen 100 days after transplant. So I'm glad you brought up the time frame, because that actually is helpful to me because it's 1 year post AML transplant. So that tells me two things. One, the stem cell transplant to a certain degree has been doing its job. Two, now we're sort of entering this chronic phase. So my differentials will change a little bit based on the fact that we're sort of in a chronic post-stem cell state. Yeah, I hope that answers your question.
Perfect. Yeah, it does. And thank you so much, Dr. Chowdhury, for highlighting that how time frame affects our differential. And I guess as you were alluding to earlier, based on the history also, we were concerned a little bit more about the nephrotic syndrome. And you said that how more than 100 days after the stem cell transplant, that is something which is seen more commonly. So I'm excited to hear from Epi that what did the physical examination reveal?
Yeah, so in terms of his physical examination, vitals, he's febrile, his blood pressure was 130/70, his heart rate was 62, stating 95% on room air, his body weight was 100 kilos, and his baseline a month or two ago, it was only 90 kilos. In terms of his heart, it was normal, no murmur, lungs are clear to my exam, no crackles, no wheezing. Abdominal exam was benign, soft, non-tender, and non-distended. Extremities, though, there was 2+ edema up to his thigh bilaterally, but no signs of infection, no erythema. And his skin, there was some MP rash on his back and also his shoulders as well. And he said that it has been kind of like fading away, fading down a little bit. And that's it in terms of his physical exam.
Perfect. And Epi, I just wanted to ask one clarifying question that this
Yep.
maculopapular rash, do we have any sort of time frame that how it developed? Mhm.
So he said that also 6 months ago, he noticed this rash as well, and he was diagnosed with the skin GVHD. That's why he's on Pred and Tacro. And it went away, but then it came back around a month also ago as well.
Okay, thank you. Thank you for clarifying that. So, Dr. Chaudhary, now we have physical examination finding of not just edema, but rash as well, and this history of GVHD. So, how does that factor into our thinking now?
Yeah, no, that's a very key component. One of my first questions when I do these review systems is and examinations is, do you have concomitant GVHD? Now, I'll get into this a little bit later, but the GVHD rash history is interesting to me because it tells me that they're prone to exactly that, graft versus, attacking another organ, self-organ. And that makes me curious about certain disorders that I'll get into in a little bit from a renal standpoint. Now, I will tell you, there's no renal criteria for GVHD. The question then, the $1 million question is there true renal GVHD, and is it from a timeline standpoint associated with GVHD in the other organs where we do have diagnostic criteria for? And more to come on that. But otherwise, from the exam, mainly, they look like they have features of nephrotic syndrome is the best I could say. Once again, the cardiac exam is a little bit reassuring from that standpoint. The hemodynamics, also are reassuring that they don't have, a florid pericarditis of some sort, opportunistic infection from the immunocompromised state of that nature.
That's great. Yeah, Epi, we are ready for some more basic labs.
Yeah, so that's a great discussion. And in terms of his labs, for his for his chemistry, sodium was 139, potassium 4.3, chloride 106, bicarb 26. His creatinine was 1.5, and his baseline creatinine was around 1 to 1.2. His calcium was 8.7, phosphate was 3, and in terms of his CBC, hemoglobin was 13.5, hematocrit 38.5, MCV was normal 82, white blood cell 6,000, and his platelet was 180, and it's around his baseline as well. And in terms of his liver function test, AST was 20, ALT 16, ALP was 66, T-Billy was 0.4, his albumin was 2.7, and his globulin was only 2. And then we also sent the lipid profile, which showed total cholesterol of 284, LDL was 213, and triglyceride was 121. And because of the swelling and questioning proteinuria, so we sent urinalysis as well. UA was clear, pH 6.5, specific gravity was 0.008, 3+ protein on the dipstick and no white blood cell or no red blood cells. And because of the 3+ proteinuria, so we sent the 24-hour urine and it came back 13.5 grams. And
Wow.
that's basic labs for now.
Yeah, those are some impressive labs. So, Dr. Chaudhary, how do you interpret these labs?
Yeah, so what I'll do is I will go back to the AKI in stem cell transplant schema, and I'll incorporate the labs if that might be easier than me commenting on each lab. So AKI in stem cell transplant patient post 100 days. Let's think about the intrinsic bucket here. If I think about the intrinsic bucket, ATN, obviously, I won't get into a whole lot of detail, drugs, sepsis, infection, doesn't appear that they're actively infected or any major drugs that stand out. I mean, they're on the tacrolimus technically that can cause ATN. Then we think about the glomerular bucket. I'll come back to the glomerular bucket. If you want to think about your interstitial bucket, stem cell patients that have interstitial AKI, there can be a couple of flavors of that as well. It could be drug-induced, and the one that we think about is penicillin. Stem cell patients usually get put on penicillin for prophylaxis. The other one, of course, the Bactrim for PJP prophylaxis. But infectious, there's some very interesting infectious interstitial AINs that can happen. BK nephropathy. BK nephropathy in a stem cell patient is a little bit different than BK nephropathy in a kidney transplant patient. BK nephropathy in a stem cell patient usually also is associated with hemorrhagic cystitis, which is not necessarily the case in the kidney transplant. We have very minimal proteinuria, no real major, fluid, systemic hemorrhage. I'm trying to say cystic hemorrhage. So it's a little bit different, and it's a little bit more drastic BK nephropathy in a stem cell patient. Adenovirus is another one that we think about, adenonephropathy. But those are my main interstitial things that I'm thinking about, and thus far the labs don't support it. Then the vascular component, TMA. So TMA obviously gets invoked pre-100 days stem cell transplant. It's usually a little catastrophic. There's very much so there will be systemic signs. By systemic signs, I mean elevated LDH, low hapto, increased retic, schistocytes. But when you get into the chronic stem cell phase, renal TMA is different. You may not have the systemic signs, and we have a lot of data saying that low hapto or schistocytes correlates very poorly with renal TMA. So definitely renal TMA is still in the picture. The only thing that you wouldn't necessarily see in a real TMA is they wouldn't necessarily have 13 grams of proteinuria. It'll be more in the nephritic range. And of course, they'd be quite hypertensive. Hypertension in a stem cell patient is basically one of the first signs of TMA occurring. So I'll leave the vascular bucket there. I guess we'll have some more clarity from that standpoint. Now going back to the GN bucket, I put in the parking lot for a sec, but let's focus on the GN bucket. Post 100 days stem cell patient, you clearly have 13 grams of protein. Obviously, serum albumin is low, so they're meeting multiple features of nephrotic syndrome. As you know, nephrotic syndrome is greater than 3.5 grams a day of protein with systemic syndromic side effects like edema and low serum albumin, et cetera. Whereas nephrotic range proteinuria is just the proteinuria, but they seem to be having features of the syndrome. So nephrotic syndrome in a stem cell patient is very interesting. So there are three that can really cause nephrotic syndrome GN in a stem cell patient. The first one is membranous nephropathy. I can talk about that a little bit later. And then second is minimal change disease. I always tell my fellows, if we ever see minimal change disease in someone that's after the age of 50, you need to look for blood malignancy until proven otherwise. It is a disorder of children. Having said that, adults getting minimal change syndrome on biopsy, there's something problematic going on that's driving it. So those are sort of the things that I'm thinking about. So my top three are differential based on the labs that you're telling me. Membranous nephropathy, minimal change disease, and then potentially thrombotic microangiopathy, although the blood pressure is not very supportive and the urine protein levels are a little bit too high for my liking.
Perfect. And Dr. Chaudhary, one more clarifying question I had was that as you were describing that how AML and all these therapies which we use for AML can impact the kidneys. Now,
Yeah.
I was wondering that in order to have the impact on kidney, do we necessarily need to have like the relapse of AML or any other organ involvement, or you think that kidneys alone can be involved in rare cases too?
Excellent question. So, in AML, so first off point, I feel a little bit better that this is not some sort of myeloid relapse because I'm assuming that the bone marrow has pretty much been clean, has not shown any relapse at this juncture, although IPI hasn't mentioned the bone marrow. So I'm assuming the AML part is sort of treated, dealt with. When we see myeloid impact on the kidneys, it usually is a representation of advanced malignancy. So what do I mean by that? So one classic myeloid dysfunction we see in the kidney is called lysozyme nephropathy, okay? So many of the monocytes in CMML, they undergo differentiation. They make this thing called lysozyme, not lysosome. That's a storage disorder. Lysozyme, it's sort of a byproduct of monocytic differentiation. What we know is that it gets filtered by the glomerulus, gets reabsorbed by the proximal tubules, and it can cause a little bit of a Fanconi physiology, AKI. So lysozyme is something we think about quite a bit when it comes to myeloid disease. But when we see lysozyme nephropathy, we know two things. One, they're on their way to progress to full-blown AML from their precursor, whether it was CML. Two, the treatment usually is treat the primary malignant disorder. So that's myeloid disorders that are active. In this case, I'm assuming the AML is not active. When you look at lymphoid disorders, you open sort of a whole other bucket of glomerular pathology, and I won't get too much into it. But one fun fact that I will leave you with is if you look at 60 to 70% of all lymphomas, if you look at a database of lymphomas post-mortem, this has been done. If you look at all types of lymphomas, almost 60 to 70% have renal involvement or renal spent, especially if it's CLL. Up to 90% of all CLLs do invade the kidneys. The only thing is they're quite salient clinically. We don't biopsy these folks all the time because they don't have overt proteinuria. It's just spots in the kidneys that it'll infiltrate to and sort of hang out at. So you don't get that overt nephrotic pathophys, but it is common for these disorders to go to the kidney outside the bone marrow.
Thank you so much, Dr. Chowdhury. I feel like that we should have a whole different separate session, and we should invite you to tell us about the onconephrology. It sounds so fascinating that how different disorders impact the kidneys. Yeah. And my last question before Epi shares new data would be that what are the subsequent tests or any other investigations that you would do to make progress now?
No, excellent question. So as I'm honing in on those three buckets, membranous, minimal change disease, and TMA, the subsequent tests that I unfortunately are not going to be very helpful because we don't have a whole lot of good serological testing. But what I do want to know, I want to know what the complement levels are, and I'll explain why. I would love to know what the C3, C4 is and what soluble C5b, C9, or the membrane attack complex numbers look like if API has those. And if he shares it, then I'll tell you why. If he doesn't, then it's going to be a mystery. No, I'm joking. I'll tell you guys either way.
That's great. Epi, you can give us more data.
Yeah, so before that, do you want to send any further investigations at this point?
Yeah, we can send, for membranous nephropathy, the most common antigen we send is PLA2R, phospholipase A2R. But generally in this patient population, this was formerly known as idiopathic membranous. We're going away from these primary membranous, secondary membranous names. It's more antigen-directed names. So PLA2R is the one that's formerly known as idiopathic or primary membranous. It's usually negative in these patients. That's the better antibody we have. There are further antibodies you can send. Thrombospondin is one that's usually found in membranous in patients with solid tumors. Exotosin is a form of membranous that happens in patients with lupus. Lupus can cause all sorts of GNs, not just lupus there's various classes of lupus nephritis. Lupus can trigger a membranous. Minimal change, we don't have a great biomarker or serology for. And then TMA. The TMA workup is vast. I do preemptively send off Adams TS. I send off my complements. I do like to send off I'd like to trend the whole hapto LDH throughout the hospital stay to make sure that we're not missing something. Of course, monitoring the TAC levels as well. The TMA workup, TMA is a big bucket of other disorders. The common ones that we always think about is Adams TS related, which is known as TTP. Then you have your atypical HUS, which is sort of now known as complement-mediated TMA. Then you have your former HUS, Shiga toxin, EHAC mediated, and of course you have your preeclampsia and drug-induced. In this case, obviously, I would want to know if this is going to be CNI-related TMA or if this is going to be complement-mediated TMA, because the management is completely different. So yes, complements and definitely the PLA2R.
Okay, so we can move on the rest of the investigations, but I will start with the imaging first. I forgot to provide it earlier.
May I ask for one more thing? Sorry, happy to cut you off. It would be nice to have a SPEP and free light chain, as those can cause nephrotic disorders as well.
Yeah, exactly. So in terms of his imaging, chest X-ray was clear. No consolidation or no evidence of pulmonary edema. His because of his tenderness in his calf, so we did the Lenny's or the ultrasound of his lower extremities, and it showed bilateral DVTs on in the right and left common femoral veins. And we also asked for the abdominal ultrasound and kidney ultrasounds as well, just to route out the AKI part. And the kidneys normal in size, no hydronephrosis, and normal echogenicity. And the liver, we did the liver ultrasound as well. It was normal. And as Dr. Chowdhury asked for the rest of the investigation, SPEP was normal, no M spike, and free light chain kappa was 32.7 milligram per liter, lambda 22.6, and the ratio was 1.45. Complements C3 was 120 and C4 was 22. We did not send the soluble C529 or MAC complex at that point in time. And then we sent in terms of the TMA workup, we also sent the peripheral blood smear, no chistocytes, LDH was normal, 200, and haptoglobin was 320, which is normal as well. We also sent the hepatitis workup. Hepatitis B of the serologies were negative. We also sent for the hepatitis C as well. It was negative. We also sent for ANA. It was positive, 1 to 40, homogeneous pattern, but the anti-double strand DNA was negative. In terms of the serum anti-PLA2R, it was pending because it takes a while. And because of the nephrotic syndrome, we also sent the 25-OH vitamin D. It was a little bit low at 18. TSH was 8.32 and free T4 was 0.8. And then we also sent the IgG levels, which is for 15. And in terms of the bone marrow, it was normal, no blast, and it showed 100% donor chimerism, meaning that the bone marrow transplant is working okay. And we also sent the echo, which showed EF of 65%. IVC was normal, by ventricular size as well, and no valvular abnormality.
Perfect.
All right.
Thank you. Yeah, Dr. Chowdhury, you can tell us that. What do you make of all these tons of data that we received?
So the beauty of what I do is I basically interpret labs and try to compare it to what the tissue is showing and make sense of it. So this is sort of exactly what I do. So interesting. So going through the labs, and I'm going to touch on a couple of things that people have commented on. So we talked about the ANA is a little bit high. So let's talk about the complements. So why do nephrologists love complements? So complements are sort of a good way to take 20 differentials and make it maybe 6. And the way I look at complements, we have to understand that there's 3 parts to the complement cascade, right? The classical system, the lectin, and then the alternative pathway. And they all converse into what's called the membrane attack complex, all right? Certain disorders I primarily classical pathway disorders. For example, lupus, C1q is, often very active in lupus. Certain disorders are very alternative pathway heavy. For example, paroxysmal nocturnal hemoglobinuria, PNH, CD55 and CD59 are anchoring proteins. When you lose them, the alternative pathway is overactive. You're making more membrane attack complex. It gets deposited in the kidney, causes TMA. Another alternative pathway dysfunction we think about is IgA nephropathy is technically an alternative pathway disorder. And in this situation, when I talk about TMAs, atypical HUS is one that I think about. So if the C3 was very low, I would start honing in on, is this an alternative pathway overactivation? Is this some sort of renal TMA going on? The acronym that I like to use for hypocomplementemia is CAMEL, CAMEL. C is cryoglobulinemia. A is usually atherembolic disease. Atherembolic disease you'll see in someone that had a right or left, usually a left heart cath, status post stents. They develop petechial rash in 24 to 48 hours. You think it's contrast-induced nephropathy, but it's actually lipodystrophy affecting, causing lipid clots in the kidneys. So atherembolic is one that really stands out post-cardiac intervention. M is a grab bag. Most of the myelomatous disorders, so M, can cause some degree of complement activation, can give you like a C3GN. E is important for all of us, endocarditis. L, lupus nephritis. And this entity that was formerly known as post-infectious GN, but we should now be calling it infectious GN. Reason being is you can have infectious GN at any point. The 14-day moratorium that we used to follow is not necessarily true anymore. You can sort of have infectious GN at any point that you're infected. So CAMEL is one that I use and I encourage everyone to use. So their complements, I believe, looks pretty normal. I'm not surprised the PLA2R is negative. Does that change anything for me? No, it does not change anything for me. And then let's talk about the M spike and the free light chain. Someone had mentioned light chain deposition disease. So when you look at, most of, I should say all of the monoclonal disorders are usually lymphoid, either B cell or plasma cell. So it would be very unusual with a normal bone marrow for this person to have a concomitant B cell process happening that's causing light chain deposition disease. Light chain deposition disease is usually from a plasma cell disorder or a B cell disorder. So, the term for those type of monoclonal diseases, monoclonal gammopathy of renal significance, I don't think this person has that. One thing to keep in mind about the free light chains, if there's AKI, the free light chains will be a little bit abnormal because it's filtered by the kidneys. And normal bone marrow also speaks against any sort of B clone or plasma cell clonal process affecting the kidneys. The echo is awesome. I'm happy about that. The Lennies are interesting. Bilateral DVTs, yes, membranous has a higher risk of renal vein thromboses, high risk of VTE. But generally with nephrotic syndrome as a whole, plus stem cell transplant, I don't know what the activity level of this patient is. I'm not totally surprised that they have DVTs. One more comment that was made that I do want to mention is the protein gap in the serum. The serum protein gap, is, I don't put a whole lot of stock in. It's super sensitive. I mean, you can get a protein gap from hepatitis, HIV. It doesn't necessarily tell me the diagnosis or help me narrow it down to any specificity. But the urine, I would have liked to know how much of the urine is albumin versus how much of it is total protein. Certain disorders give you more total protein, and certain disorders are very albumin predominant. I'm just going to suspect that this is very albumin predominant because most GNs are very albumin predominant.
Perfect. And thank you so much for highlighting all the comments, Dr. Chowdhury, and also describing your thought process simultaneously. I guess my one last question before Epi gives us other further investigations would be that in a case like this, which we often face this conundrum on floors when we are internal medicine physicians, that how much is noise and how much is signal? Like we know that this patient has very heavy oncologies, AML, all this treatment. So how do you decide that whether the complication which we are seeing now is not related to that, or it is actually related to that? Because it could be just unrelated as well, right? So what
Yeah.
makes you make that decision?
No, excellent question. So, the ANA to me is pure noise. And that a little bit comes with clinical gestalt and the realm of things that, this patient has. The second part is when you have the tissue, you have to critically look back at the labs and make sense and merge the two, because you need you need a pretty good marriage between the two. If your serology is saying one thing and the tissue is saying something else, then perhaps, at some point the serology is going to declare itself into something ominous, or you have a bad tissue sample. So oftentimes, the ANA usually, more often than not, that level is noise to me. Now, if you tell me, look, the ANA is super positive and they have, features of systemic sclerosis, then, the TMA gets invoked very high. The stem cell could have triggered immune activity and sort of made that quiescent autoimmune syndrome just sort of manifest itself. Ultimately, most GNs, are autoimmune disorders. So therefore, anytime you have a positive ANA, it doesn't really help you a whole lot. But once I get the tissue, I'm going to go back to the labs and sort of put the puzzle together.
Perfect. Thank you so much,
tighter.
Dr. Chowdhury.
Yeah.
Yeah. Thank you. Happy you can give us more data.
Yeah, actually, the next one gonna be the kidney biopsy though. So I guess so what is on the top of your list right now?
Yes.
While API does that, obtaining a kidney biopsy acutely post stem cell transplant, I will say, is very difficult because everyone's platelets like 20. So oftentimes when we're invoking some of these hyperacute syndromes, especially TMA, we'll often treat before we have tissue diagnosis. And that's an area of expert opinion that gets complicated because the question always becomes, when do you stop the treatment? But we were fortunate that this is a chronic disorder. Post 100 days, the platelets recovered enough for us to get a kidney biopsy. It's often not the case.
Yeah, so the challenging part for this is because of the history of DVTs. So we put the patient on the heparin drip because we anticipate the kidney biopsy. So that's why we need to, start heparin drip rather than Eliquis or, the DOACs. So we started him on the heparin drip and then performed the kidney biopsy. And do you want me to tell the result of the kidney biopsy, or you wanna give us like top three
I think
differentials or?
Yeah, so I think it's membranous or minimal change. To me, it's going to be either of the two. Membranous stands out a little bit because of the VTE. I don't think this is going to be TMA based on the hemodynamics
Yeah, I
and the
agree.
complement activity.
Yeah, and with this massive amount of protein, I guess the
Yeah.
TMA is less likely. So I agreed. So we performed the kidney biopsy, and it showed okay. So it showed on the LM, it showed double contour.
Light microscopy,
then-
right? LM.
Yeah, exactly. Yeah. The light microscopy showed double contour, and then on the silver stain, it also showed the craters and spikes as well. And then on the immunofluorescence, it showed IgG and C3 deposits in the capillary wall. And then on the EM, which is the electron microscopy, showed subepithelial deposits and also some mild, very mild deposits in the mesangium as well. And then there's a diffuse podocyte effacement, which all of that is mostly consistent with membranous nephropathy. And we also stained for the anti-PLA2R. It was negative, and in the serum, it came back negative as well.
So I'm going to make a quick comment. Well, I have a lot of comments to make, but I'll make one comment on the biopsy itself, and then I'll let you guys facilitate. So obviously, the primary diagnosis is membranous nephropathy. One thing that people fail to realize is that when we obtain these kidney biopsies, there's often 2 or 3 things going on. oftentimes it'll be the membranous or minimal change or lupus with diabetes in the background. So everything has some degree of contributory effect. And the one thing that stands out to me is a statement on double contouring on light microscopy. So that's usually, you know, the glomerulus showing sort of the GBM showing double looping around. And classically, you actually do see that in TMA. So do they have a little bit of chronic TMA? It's not unconceivable. They're on tacrolimus. And then this leads to your previous question is, you know, how do you interpret serology and sort of make that marriage? Well, even if they had some chronic TMA, the serological workup is not really consistent with that. So I don't necessarily need to go hunting for an active TMA because as you can see, the complements are normal, the hemodynamics are not normal. So I'm going to target the predominant feature on the tissue, which in this case has to be, you know, the membranous. The PLA2R negativity, I mentioned this earlier, just because it's negative does not mean this is not membranous nephropathy. PLA2R membranous nephropathy is one form of membranous. It's the more idiopathic form. We increasingly learned actually in two years ago from the Mayo Clinic group that the antigen that targets that forms a flavor of membranous in stem cell patients are triggered by this thing called FAT1, procatehedron FAT1. They are expressed in podocytes. And for whatever reason, the stem cell triggers an antibody antigen complex against it, leading to podocyte death and podocyte foot process effacement. So this is likely going to be a FAT1 procatehedron membranous nephropathy.
Yep, exactly. So,
and there's no serologies for that. It's staining based, sent to Mayo Clinic.
right. So, it's continued. So after the kidney biopsy, it's consistent with membranous. So we started the patient on rituximab, which is the anti-CD20 antibody. And we started torsemide, actually Lasix first, and then switched to torsemide, which is the loop diuretics long-acting to help with the swelling. And also add the metolazone as well to augment the diuresis. And then his weight came down from 100 to 92 kilos prior to discharge. And also we switched heparin drip to Eliquis 5 milligram twice a day, adding losartan to help with the blood pressure and with the proteinuria as well. And his creatinine prior to discharge was around stable at 1.5. And then we follow up the patient 1 month later, and his albumin was started to climb up to 2.8, and urine protein is around 7, and urine albumin was around 5 grams.
Thank you so much, Happy, for giving us that final results. And Dr. Chowdhury, I guess I wanted to ask that once we diagnose this protocadrine FAT-mediated membranous nephropathy, does the management usually differ from other kind of membranous nephropathy, or it really doesn't differ that much?
Yeah, so I'll answer the management question. I'm also going to touch on a question that came up here. So when it comes to nephrotic disorders, or proteinuria, I should say, one thing we didn't really talk about is, you know, we like to bucket things into nephrotic versus nephritic. As you progress in your training, you'll learn that something can start off as nephritic looking, and then once it's burnt out, it could be full-blown nephrotic. ANCA is a very common example, lupus. You can have nephritic lupus nephritis that becomes membranous lupus, which is nephrotic syndrome lupus. Now, why I brought this up was someone mentioned what is the difference between dense deposit disease and membranous nephropathy. So I'm glad you asked that question. The main difference is that dense deposit, also known as, or form also known as C3GN, they are alternative pathway disorders. So the complements would have been abnormal. They would have had a more membranoproliferative pattern on the light microscopy, whereas membranous nephropathy has a very normal to spike and dome pattern on light microscopy, and it's not a complement disorder. Membranous is a autoimmune disorder from whether it's a procatehedron, whether it's the the PLA2R. So that's the difference between the two disorders. The second thing that I wanted to mention, because the paper just came out like 2 days ago, the New England paper on this, minimal change we're also learning is an autoimmune disorder. My colleague here, Astrid Wins, she sort of pioneered the identification of the antigen antinephrin that's found in minimal change disease. And so what I'm getting at is most of these nephrotic disorders are some sort of autoimmune disorders, and there's a whole bunch that are complement-mediated disorders. In terms of management, we're sort of in the realm of very expert opinion. The incidence of these cases are very, very few around, in the United States. So most of the management that I propose in these sorts of disorders are expert opinion based. My go-to is usually a steroid-sparing regimen. I usually favor using rituximab, which is a B-cell depleting agent, targets CD20. You guys may have heard of the common side effect of rituximab. I mean, it's not a common side effect, but the things you want to be aware about is hepatitis B reactivation. So you want to make sure the hepatitis serologies are up to date. And some very rare complications would be a progressive multifocal leukoencephalopathy. I have not seen it, but it's reported in the literature. But rituximab sort of works for all types of membranous nephropathy, and I've had pretty positive experiences. I usually do 2 grams every 14 days and then wait 6 months and follow their CD markers to see if the rituximab is fading away or becoming less therapeutic.
Perfect. Thank you so much for highlighting the management aspect, Dr. Chowdhury. And before we end, I wanted to ask Epi that such a crazy case, and how was it like for you to take care of this patient? What was the team thinking? And how did you confirm the final diagnosis with Dr. Chowdhury was suggesting?
Yeah, so it's a very interesting case because like we did not, normally see the post-stem cell transplant that much, even though like our hospital is one of the centers that do a lot of stem cell transplant as well. But my initial thinking when anyone came in with bilateral legs edema, we are thinking like Dr. Chowdhury said, big buckets are is it cardiogenic, is it from renal nephrotic syndrome, or is it from like local, for example, like DVTs sometimes can cause the swelling as well. It's unusual to have bilateral DVTs except in nephrotic syndrome, especially with the membranous. And other things is cellulitis, but this patient doesn't have any evidence of infection. So most likely nephrotic, we check UA, urine proteins positive, we check 24-hour urine. Most of the time we send both UACR, urine albumin and urine protein as well to see whether is there any dissociations like we normally see in myeloma or CAS nephropathy. And after we nail down to nephrotic syndrome, as we see here, low albumin, high LDL cholesterol, which is a big picture of nephrotic syndrome. We're thinking about membranous, minimal change, or amyloid. So that's the 3 big buckets under nephrotic syndrome. Sometimes we can see collapsing FSTS or FSTS in general as well. So we sent SPEP, free light chain, hepatitis to rule out the secondary cause of the nephrotic syndrome. And we normally end up performing kidney biopsy just to confirm the diagnosis. And in this case, it's membranous.
Perfect. And yeah, go ahead, Dr. Chowdhury.
Yeah, so I guess I can give you some of my final thoughts. One thing,
Yes.
one loose end that we should tie up is the graft versus host disease comment. So we have translational evidence. So first thing we need to understand is that we don't have a renal diagnosis for graft versus host disease. So what we do know is from a translational standpoint, certain biomarkers that are elevated in graft versus host disease are also found in the urine, and they both tend to be elevated around the same time if a stem cell patient has a graft versus host disease. And they actually translational studies have been shown is if you have elevated graft versus host disease biomarkers, your chance of proteinuria is higher. So we do believe that the stem cell itself is sort of attacking, in this case, the podocyte, which is the host, through various mechanisms that we haven't mapped out. So I would call this a graft versus host disease manifestation in the kidneys. The second part of this is, going back to your fundamental schemas is the key here. Knowing the AKI compartments is basically the foundation. The layer was just adding that this is a stem cell patient, but the fundamental problems are often very basic if you think about it. And the last thing I wanted to mention is, as nephrologists, we're basically acid-base physiologists, but we do a little bit of everything: hematology, heart failure, rheumatology, as you can see. And now we're starting to venture into the heme and the onc world, and hopefully people are excited about that and do want to learn more about that. And we're always welcome to have people to reach out to us and get our opinion on things.
Right. I think, Dr. Chaudhary, after listening to today's session, so many people will be interested in this field because you outline everything so eloquently. Like you could see in the chat that how much love is flowing in the chat for you and Epi as well. So thank you so much, Epi, firstly, for bringing a brilliant case, and the way you streamlined the presentation is amazing. I learned a lot from it. And of course, Dr. Chaudhary, the mastermind in onco nephrology, I must say, we will definitely want to have you guys again, specifically for the onco nephrology. Not related to case, but just all this cool FAT Pro cadre in Play 2R and all the good stuff. So thank you so much again. And thanks to Elena, Gia, and Kushal for helping with the whiteboard as well. And hope to see you next time, guys. Thank you.
Thank you, everybody.
Thank you
This was
for
fun.
having us.
Take care. Bye-bye.
Great.